Hey guys, we're back in my basement. I really gotta clean this place up. Okay, so now we're talking about first couple neuro diseases or pathologies we're gonna get into in this course. So we're looking at strokes, we're looking at seizures. These are gonna be the first two. All right, so we're talking about strokes. What causes it? It's caused either by a clot or a blockage, something blocking the brain, blood flow to the brain, excuse me. Could be from a narrowing of an artery. Could be a clot has broken off, like an embolism has broken off somewhere else. Maybe you're an AFib and you're throwing clots all over. One of them gets stuck in an artery in the brain. The parts after that artery start to die because they're getting ischemic, no oxygen. And then we start getting these deficits. And the classic deficits that you're going to see are facial droop, arm drift, slurred speech. You can also get some visual issues like nystagmus, and you can get some aphasia, can't speak, can't swallow, both those. And you could also get some like complete total weakness on one side, like you're neglecting that side. So the acronym that we use to assess would be FAST, and that gives us our initial kind of assessment. Oh yeah, this is having a stroke. You can also use the last part, VAN, visual acuity aphasia, and neglecting one side of the body, to let you know if there's a large vessel involved. So I would do the fast part while I'm on scene, the van part when we're in the truck, getting ready to roll. All right, so what's special about strokes? How do we treat them? Oh, excuse me, got ahead of myself. Stroke, other type of stroke. We got our hemorrhagic strokes. So one's a clot, the other one's when a blood vessel just bursts. Can often be caused by hypertension or just an AV malformation. Both of them will often present the same way. There is a subset of headaches like thunderclap headaches or the subarachnoid hemorrhages that can present a little different, but overall, vessel breaks, we can call that like a stroke. It's impossible for us to tell in the field if it's a clot or a blood vessel is ruptured, so we're going to treat them both the same, and this will tie in a couple minutes. All right. Fast forward again. Now we're into treating the patient. So we get on scene. What are we looking for? That facial droop, that difficulty speaking, weakness on one side, or difficulty moving around. You'll often see them if they're having that full body negligence or neglect, excuse me, that they're completely leaned over to one side. So strokes are often really easy to see if they're having the classic stroke. So we get on scene. We do our scene assessment. We're looking for those things. ABCs. Unless they're unresponsive or having a seizure, strokes can usually manage their airway. Again, it depends on where in the brain we're having these kind of symptoms. We move down to our assessment. We're asking our neuro questions. We're looking for numbness, tingling, weakness anywhere. When we're doing our chief complaint, so the first thing we do in that assessment, we need to do FAST. So do our Cincinnati stroke assessment. If they failed the Cincinnati stroke assessment, either one of those categories, partner, grab the stretcher. I'm going to finish the assessment. We're going to get going. It's really important when I say that we have to get moving, but we have to get this information, at least the basic information, before we leave the scene. So before the wheels start turning. So get in the truck, get moving, get as quick as you can, but also make sure you get OPQRST ample, head to toe, and a full set of vitals before you leave the scene. Really important vital for stroke, blood glucose. Blood glucose, hypoglycemia can present like a stroke. So be really careful. You don't want to drive, activate the stroke team, and then find out the guy just needed a sandwich. Awesome. Treatment-wise, there's really nothing we can do for strokes other than that rapid movement. It's all about recognition, calling ahead, activating your stroke team. They'll get a CT scan going so they can tell if it's a clot or a bleed. The treatment for a stroke is TPA or TNK. So it's a clot-busting drug. Streptokinase is another one they use, and it helps break up the clots. But obviously, if we give that to a brain bleed, not going to end well. So they need to confirm that. So that's why we don't have that drug in the field for strokes. Awesome. Moving away from strokes, now we're into seizures. Seizures caused by a whole bunch of conditions. Could be from epilepsy, and the brain's more likely to have seizures. Can be drug overdoses. Hypoxia can cause seizures. You've probably seen people who have fainted, and they have a little hypoxic seizure on the ground, and then once they hit the ground, they wake up. Common, loads of different reasons, ways you can have seizures. Seizures can present like what you would consider a seizure, that full tonic clonic movement, a complete seizure. Or you can get the focal seizures or partial seizures. I'm going to say Caesar. And those would look like, they're common in kids, lip smacking, looking off into the distance. Sometimes they'll get facial twitching or singular body part twitching. That's a sign that they're having a facial or a partial seizure. If somebody's having repeat partial seizures or repeat complete seizures, tonic-clonic seizures, or they don't wake up after their seizure, right? They don't regain full use or full use level of consciousness, then we would call them status epilepticus, and they need to get to the hospital quick. Need to get them treated. Yeah. So we're doing our scene assessment. We're looking for somebody who's having a seizure. They're going to be on the ground, probably not going to be shaking by the time we show up as EMS. So they're probably not going to be doing those tonic-clonic movements. They're probably going to be confused and very sleepy. Think of seizure like a big muscle cramp. Your brain is having like a muscle cramp. It's getting everything to tighten up. After it relaxes, you're just exhausted. So think of it that way. You're moving a lot of muscles, burning a lot of calories. So seizures, patient's going to be tired. And that tired phase is called postictal. All right. So we've got our postictal patient. It's just to keep them relaxed, calm, laying flat. If the patient's still seizing when you get there, you might have to manage their airway. Best thing to do is just hold their face, put a non-breather over their face, and just wait for the seizure to end. Make sure you don't hold them too tight so you hurt their C-spine, but make sure they're not banging their head on the concrete. Seizure should last for 1 to 2 minutes, and then it's done with. Other than that, once the seizure is over, we got that postictal phase. We're just doing our good assessments, looking for a cause of the seizure. Maybe it's in their history. And then if they've had a history of seizures, maybe this is the patient who stays home if this is a normal seizure and something happened. But somebody who's never had a seizure before, or there's another cause of the seizure, we want to get them to hospital to get them investigated. So normal transport, take your time, always be watching for more seizures. If somebody does have a seizure and you have an ACP around, they can look at a benzo like Valium or Versed or Ativan. Sometimes it goes IM, sometimes it goes IV, sometimes it goes in the nose. All great ways to do it. Yeah, so that's pre-hospital management of neuro cases. Cool. See you in lab.